morning. It's my pleasure to introduce Professor Anne Holland and Joanna Lee from their group, who are going to do the presentation today. Joanna was telling me that she's hopefully nearing the end of her PhD, but I think with it being such a clinically focused and patient-dependent endeavour, there's always these COVID issues that keep popping up all the time, and I think you should be commended for getting as far as you have in recent times. So with that, I might hand over to Anne to do the formal introduction and perhaps just give us a little bit of a sense of what her group's been doing. So over to you, Anne. Oh, and congratulations on your ascendancy to the Thoracic Society presidency. If I think I've said that before, but anyway, for this forum, we look forward to your tenure. So
thank you very much. It's it hopefully will be good to have a friend to pulmonary fibrosis in that role. So I'll step up to president next March. Yeah. So thanks everyone for the opportunity to be here today. I just would like to say a couple of words about our group, and then I'll hand over to Joanna for her presentation. So we're based at Monash University and Alfred Health in Melbourne. We have a research program that aims to improve the lives of people with chronic lung disease using non-drug treatments, so particularly focus on rehabilitation and self-management and oxygen. So we have a strong focus on pulmonary fibrosis. It's not all that we do, but certainly that's a huge part of our work. We've been interested for a long time in the types of treatments that people can use to improve their symptoms, improve their well-being, and improve their ability to do the things that are meaningful to them in their lives. So this piece of work that Joanna is going to present today has been a huge part of that over the last few years. Joanna actually started work with us before her PhD, so she's been working on pulmonary fibrosis research even before she started her PhD candidature, looking at things like supportive care interventions for people with pulmonary fibrosis. And we are fortunate that she then decided that she would come on board as a PhD candidate a number of years ago, specifically to explore the area of self-management, which is a really interesting and emerging area for pulmonary fibrosis. So with that, I will hand over and welcome Joanna to tell us about the work she's been doing in her PhD.
Thanks so much, Anne. I feel very fortunate to be able to be involved in this project. So thank you. I'll just share my screen now and see whether you can see it. So can you see? Yep.
Yep. And if
you can see the presenting. Yep.
That's good.
View. Without my notes?
Without your notes. Yep.
Great. Good. Thank you. Okay, so hi everyone. Today I'll be talking about my PhD project on self-management for pulmonary fibrosis, and as Anne mentioned. So my supervisors are Professor Anne Holland and Dr. Gabriella Tekilis. So I'll start by talking about the background and rationale for this project, the overarching aims and the research questions that will be addressed through the studies included in this project. I will then present the 2 studies that have been completed already, and then talk about my current pilot study. And to finish with, I will outline my next steps for the next 12 months. So as you all know, PF is characterized by scarring of the lungs, and the common symptoms of PF include dyspnea, chronic cough, and fatigue. And although the symptoms and disease progression can vary between individuals, PF often has a negative impact on many aspects of a person's life, such as their mental and social health, their employment, finances, and their ability to perform daily tasks. And in previous studies, people with PF have expressed an interest in self-management and learning how to live well with the disease, while health professionals have also outlined the benefits of patients taking an active role in their healthcare. So there are a couple of quotes that I have extracted from a couple of articles that I was reading for the reference. So self-management interventions have previously been defined as structured but individualized interventions that often consist of several components aimed at motivating and supporting people to adopt positive health behaviors and to develop skills to manage their disease. It is strongly recommended in other lung conditions such as COPD and asthma, as evidence shows that these type of interventions can improve quality of life and reduce hospital admissions. In COPD, the common components included in a self-management intervention are lifestyle components such as exercise, smoking cessation and nutrition, managing symptoms, medications, NACU exacerbation, action planning, end-of-life planning, and psychosocial support. So although people living with PF and health professionals have acknowledged the value of self-management, it remains a novel concept in PF. The disease was generally considered untreatable with a very poor prognosis, and therefore there was little role and opportunity for self-management before the antifibrotic era. But with the current antifibrotic treatments and medications providing some hope, people with PF and health professionals have been expressing more interest in self-management. However, unlike other chronic diseases like COPD and asthma, there is no consensus regarding the components that define a self-management intervention for PF or having a standardized self-management package. So to address the current research gaps, this project aims to develop a consensus-based self-management package to support people living with PF, and then to test the feasibility and acceptability of this package. So to address the aims of this project, I will be addressing the following research questions. So what does self-management mean to people living with PF and healthcare professionals in the field? What are the support needs and expectations of self-management in PF? What are the essential components of self-management in PF? What would be the best format and method to deliver a PF self-management package? So these 4 questions were addressed through a qualitative study and a Delphi study, and the findings were used to inform the design of a PF self-management package. So now we need to evaluate the, that's it, yeah. Now we need to evaluate the self-management package to determine how acceptable and feasible it is to deliver this intervention to support people living with PF in a clinical setting. And in addition, we will complement our findings by conducting a scoping review that will document what interventions have been used to support people with PF in self-management so far, how effective these interventions are, and what tools have been used to measure these, to measure clinical outcomes. The study 1 was conducted between April 2020 up to February last year. So this study used a qualitative method to explore the meaning of self-management in PF and to identify and aim to identify the expectations and patient needs regarding self-management from the perspective of those living with the disease and health professionals providing PF care. Semi-structured telephone interviews were conducted using interview guide. The audio recordings of the interviews were transcribed verbatim, and the transcripts were analyzed by 2 researchers using a thematic analysis approach. We interviewed health professionals with an expertise in PF located in Australia that were identified through professional networks and word of mouth. And we also included Australian adults living with PF that were recruited from the Alfred ILT Clinic and our Pulmonary Rehabilitation Program. The interview with the participants with PF explored areas such as the things that they do that they think help them stay well with PF, the things that they find challenging to manage, the support and information that they find helpful when managing PF in everyday life, what self-management actually means to them, and what do they think is needed to support them to manage their health. And for the health professionals, we asked what they think patients can do for themselves to help them stay well. What aspects of care do they think would be challenging for patients to manage on their own, and what patients would need to best manage their PF. We also asked the health professional as well what self-management means to them. What components do they think would be useful to be included in a self-management intervention in PF, and what are the challenges that they see when delivering such an intervention. 33 interviews were completed, including 18 people with PF and 15 health professionals. So of the 18 participants with PF, 78% had IPF. The ages range from 49 to 88 years old, with a mean age of 72 years. Mean time since diagnosis was 4.4 years, and based on the TLCO percentage predicted, their conditions range from mild to severe. And just over half of the participants were using antifibrotic, and about 20% were using oxygen therapy at the time of the interview. So the health professional group included predominantly respiratory physicians, and then included 3 ILD nurses and a couple of physiotherapists across 4 states in Australia. Their experience in PF care ranged from 6 to 20 years. So thematic analysis showed that both groups thought that self-management was about an individual taking personal responsibility and being in charge of their own health. Participants with PF often said that it was their duty to do the best that they can to manage their health and to make decisions about their own care so they have some control over their lives. And similarly, health professionals felt that self-management is about the person or the patient taking ownership of their health and actively participating in shared decision-making about their care. 26 components were identified as being important for self-management in PF, which include understanding the disease and prognosis, treatment options, managing symptoms, medications, comorbidities, mood, activity of daily living, lifestyle components, including regular physical activities, nutrition, smoking cessation, vaccination, recognizing the exacerbation, using an action plan, as well as social support and end-of-life planning. 3 common themes emerged from the interviews with both participant groups. Both groups agreed that effective PF self-management required individualized components that are tailored to the person's needs and goals, and acknowledged that these might change during the course of the disease. It was also highlighted that people with PF would need reliable information and knowledge to help them understand and manage their disease and treatments, and to make informed decisions about their care. And then various types of supports as well to help them cope with the disease, such as support from their health providers, their family, and their peers. Four other themes emerged from interviews with the health professionals. They emphasized that PF self-management would require managing the patient's expectations about their disease and treatments, helping them understand where the disease can take them and the benefits and risks of their treatments. They also highlighted that support and information must be accessible to the patients. So some health professionals also talked about the risks of self-management, where they think that the patient can potentially miss out on treatments in critical times if they don't recognize the important signs of disease progression. And some suggested that self-management strategies in PF might be different to other lung diseases because there are limited action that the patient can take in response to deterioration in PF. 2 other themes emerged from the interviews with those with PF. Many participants wanted easy access to their personal health data, such as the lung function test results, to help them track disease progression and figure out what they can or can't do, and what they should be doing to improve their health. So some participants thought that self-acceptance of their disease is an important part of self-management, accepting where they're at and where the disease can take them, and then finding a routine that they're comfortable with when coping with the disease. So this study has identified components of self-management that are specific to PF and provided a foundation for the design of a future PF self-management package. So there was mutual agreement between those with PF and health professionals that effective self-management required individualization, support, and information that is easily accessed by the patients. People with PF expressed that they highly value having access to their personal health information and highlighted the importance of self-acceptance. And then on the other hand, health professionals pointed out some unique features of self-management in PF, including the support required for the patients to have the appropriate expectations about the disease course and treatments, which might also then include helping the patients interpret their clinical test results. Another important feature of self-management in PF that the health professional pointed out was that it was related to the limited action that patients can take in times when they experience deteriorations in their health. So our study findings suggest that teaching patients how to identify the important signs would be very important so they can seek help from their doctors promptly. So following the qualitative study, where we have identified some components that are thought to be important for self-management in PF, a Delphi study was conducted between February to June last year to gain consensus between those living with the disease and health professionals about which of these 26 components identified in our qualitative study are essential to be included in the self-management package, and then what is the best format and mode of delivery for the package. The Delphi method is an iterative process that is used to gain consensus of expert opinion on a topic by using a series of questionnaires and sometimes in combination with interviews and focus groups. And in this study, health professionals from different countries who have an expertise in PF were identified through peer-reviewed literature, professional networks, and word of mouth. And then we also included Australian adults living with PF who we recruited through the LFA's patient e-newsletters and social media platform. And we also contacted those in our previous qualitative study who expressed interest in future research. The study involved 2 rounds of online survey that were completed by the health professional and then 2 rounds of patient focus groups. In round 1, we asked the health professional to rate the importance of the self-management components identified in our previous study and the format and delivery method for a self-management package. The survey results were then presented to the patient focus group for validation. And in this round, all participants were invited to add components that weren't initially included. In round 2, feedback from the patient focus groups were included in the survey, and we asked the health professionals to rate the items that didn't reach consensus and any additional items that were suggested in round 1. So lastly, we conducted a final patient focus group to discuss the survey results and to validate the discussions about the design of the self-management package. In the survey, a 5-point Likert scale was used for the health professionals to rate the extent they agree that each component is essential for a PF self-management package, as well as some statements regarding the format and delivery of the package. So when an item had a median score of 4 or more, meaning most participants agreed or strongly agreed that the item was essential, and the interquartile range is 0, meaning high consensus. It was recommended for inclusion in the self-management package and not included in the round 2 survey. And then when an item had a median score of equal or less than 3, meaning most participants responded neutral, disagreed, or strongly disagreed that the item was essential with a high consensus, this item was then removed and no longer considered. And for any other items that had a low consensus, it was retained for reconsideration in round 2. The focus groups were conducted online using Zoom. Each discussion was facilitated by 2 in-study investigators and lasted for approximately 90 minutes. 45 health professionals completed the first survey and 51 completed the second survey. The majority of participants were respiratory physicians, and we also had some nurses, researchers, and allied health professionals. About half had between 11 to 25 years of experience in PF care, and around 20% had over 25 years of experience. Most were working in Australia or New Zealand and North America. The focus groups were comprised of 6 participants who have PF, 5 of which took part in both rounds of the focus group. The age of the participants ranged from 36 to 75 years old, with 2/3 being male. We included participants with both IPF and non-IPF diagnosis who had a wide range of lung function levels. Over half of the participants were on antifibrotic therapy, and about 1/3 were using supplemental oxygen or immunosuppressants. So based on our findings, based on our definition of consensus, 11 components were considered essential for self-management in PF in the surveys, which were also endorsed by the participants in the focus groups. These components cover various areas of PF care, including the management of symptoms, comorbidities, and medications, understanding treatment options, including oxygen therapy and pulmonary rehabilitation, and other supportive components as well. So during the patient focus groups, participants forged the views that regular physical activity and managing mood were also essential components and should be included in the self-management package. They also agreed to combine regular physical activity with another item that already reached consensus, which was the role and importance of pulmonary rehabilitation. And therefore, a total of 12 essential components were recommended for inclusion in the self-management package. Many participants strongly agree that these 5 components were essential for self-management in PF. However, these items didn't reach consensus, so they were deemed as being desirable components of PF self-management. So other components that were considered during the Delphi process included managing cough, activities, daily living, and sexual problems, vaccination, action planning, and how to reduce the risk of an exacerbation, nutrition, advice on traveling, as well as other support components such as social support, peer support, support for the family, and then information about monitoring the disease and how to prepare for a medical condition, for a medical consultation. And while consensus was low for these items, both groups agreed that they might still have an important role in self-management of PF. We included 8 statements in the surveys related to format and delivery of the self-management package. and of which 2 of these statements reached consensus and were also endorsed by the focus groups. Both groups agree that the components of self-management must be tailored to each person's specific needs, and that goal setting and feedback are essential for effective self-management in PF. So in conclusion, health professionals and people living with PF identify 12 components as being essential for self-management in PF, covering areas from understanding treatment options, managing symptom and medications, maintaining regular physical activity, to accessing community support. While 5 of the components didn't reach consensus, they remain desirable in the self-management of PF. Both groups agree that the components must be tailored to the person's specific needs, and that goal setting and feedback are critical for effective self-management. The findings of this study provided some more guidance on what components are essential for self-management in PF, which can be used to inform the future design of self-management interventions. A range of desirable components of self-management related education were also identified. So these components may be important for individual patients and may be delivered if the resources are available. And lastly, the impact of self-management in PF needs to be investigated through future randomized controlled trials. So the findings from the Delphi study were used to develop a self-management package. This package includes the 12 topics identified as being essential for self-management in PF and incorporates individualization, goal setting, and feedback. So besides the input from our team at Monash, we were also very lucky to have some input from the Alfred clinical team and a couple of patients who have PF. So in the next few slides, I will provide an overview of the package. So this package begins with an outline of the package aims, contents, and how to use it. The participants are encouraged to inform their healthcare professionals that they are using this package. So these boxes are used throughout the whole package to prompt them to discuss any issues or concerns with the healthcare team. The introduction section is then followed by a getting started section. The aim of this section is to help the participants reflect on their own situations, such as any questions that they may have about their lung condition, the things that they think are important to them when managing their health, and what they would like to change so they are able to better manage their condition. This section also provides some guidance on setting health-related goals. So each module includes information that is general across all PF diagnoses and suggests some tips and strategies for managing the aspects of PF that the module is addressing. For example, in this module, it's managing shortness of breath. And as they read through the module, there are questions to guide the user to think about their own situation again. For example, in this module, we asked, what are the things that make them feel short of breath? And what challenges that they face when they feel short of breath. So at the end of each module, there's a list of online resources that are relevant to this topic. Many of these resources are derived from the Lung Foundation Australia, but materials from other reliable sources such as the PF Foundation and Palliative Care Australia, they're also included. These resources include web pages, booklets, fact sheets, and videos. If the participant is using a PDF version of this package, they can click on the titles and it will take them straight to the resources. And if that module mentions any information about that is related to another module in the package, they are directed to these modules for more information. So there are some more prompt questions at the end of the module to guide the participant to think about where to from here. So for example, the new strategies that they might want to try, Do they have any other questions about the topics, and what do they need to do to find answers? Hang on, it's not moving. Here we go. A symptom diary is also included in the package, which was designed to help participants monitor symptoms and be aware of their own situation once again. So, for example, what makes them feel better or worse, and how the symptoms is affecting their life, and then prompting them to contact the doctors if they do have any concerns. And then finally, there is a glossary of terms that is located at the end of the package. So currently I'm conducting a pilot study which aims to test the feasibility and acceptability of delivering this PF self-management package. We also aim to collect some preliminary data on self-efficacy, health-related quality of life, dyspnea, physical activity, treatments, and healthcare utilization, comparing between the intervention and control group. And then lastly, to examine the experiences of the participants in the intervention group about using the package. So this study comprises of a randomized control trial comparing between the intervention group who received the PF self-management package and then the control group who received standardized information about PF. And then also the other study is the qualitative study that aims to gain insights into the participants' experience of using the intervention. So we're including adult patients who have a physician-confirmed diagnosis of fibrotic ILD. They will have to be able to read and speak English and to be able to consent for themselves. We are looking to include a range of patients from newly diagnosed to those who have been living with the disease for many years. We are excluding those who can't communicate in English or give consent due to cognitive impairment or other reasons that affect their ability to consent. The primary outcomes of this study are the feasibility of the study protocol and the acceptability of the intervention. So in this study, feasibility is defined as recruitment of at least 25% of those who are identified and meet the eligibility criteria, randomization of at least 80% of those recruited, and at least 80% of participants completing both baseline and post-intervention assessment. And then acceptability of the intervention is defined as at least 80% of participants accessing a minimum of one module of the self-management package, and at least 30% of them setting one goal. The secondary outcomes of this study include self-efficacy, which is measured using the general self-efficacy scale, health-related quality of life measured with the Kingsbridge ILD and the EQ5D5L questionnaire, dyspnea measured with the MMRC dyspnea scale, and a 7-day monitoring of their physical activity using a physical activity monitor called StepWatch, which measures the number of steps taken per day. So these 4 outcomes require the participants to complete at both baseline and after they complete the intervention. We also ask the participants and review their medical health records to see what treatments they are using for PF, and then also hospital admissions and visits to any emergency departments, participation in pulmonary rehab, and whether they have started using any additional health services since participating in the study. We aim to include a total of 30 participants in this trial, 15 in each group. And we are recruiting from the Alfred ILD Clinic and PR program. In this recruitment process, clinicians briefly introduce the study to their patient and seek the patient's permission for a researcher to contact them for further discussion about what the study involves. Patients providing approval are then contacted by the study researcher, who will then provide them with a PRCF and proceeds with the consent process if they're happy to participate. So patients have the option to return a signed consent form by mail, email, or mobile SMS. They can also provide a verbal consent over the phone. For baseline assessment, the participants will be asked to complete 4 questionnaires to assess their self-efficacy, health-related quality of life and dyspnea. They have the options to complete them online, in person, or have a hard copy of the questionnaire sent to them. The participant will also be asked to wear a stopwatch for 7 consecutive days, which is worn on the ankle. So once baseline assessment have been completed, participants are randomized to either the intervention or the control group. The intervention period is 8 weeks for both groups. Participants in the intervention group will receive access to the PF self-management package, a Life with PF booklets that's developed by the LFA, and support from a health professional via telephone or Zoom at week 1, 2, 3, 4, and 8 following randomization. Participants in the control group will receive a web link for them to access PF-related information on the LFA website and the Life with PF booklets. They will also receive some calls at the same week. However, these calls will only be for attention control only. So this is the Life with PF booklets, which includes information about different aspects of PF, such as understanding the disease, diagnosis and monitoring of the disease, treatment options, managing symptoms, how to maintain a healthy lifestyle, as well as end-of-life planning. So both the intervention and the control group will receive a copy of these booklets. For participants in the intervention group, besides the self-management package and the Life with PF booklets, they will have contact with a health professional by phone or Zoom. The purpose of these calls is to facilitate the use of the self-management package, and depending on the participants' needs, they will receive assistance in different things. So the first call will happen 1 week after randomization, and during this call, the staff might help the participants identify the appropriate modules to read, setting a goal, and building a plan to reach that goal. During the remaining calls, the staff will then discuss with the participants their progress on, going through the modules that they've chosen to read, their progress on reaching their goal, and any challenges that they might have experienced, and where appropriate, the staff might also provide some feedback and clinical recommendations to the patient or to the participants. Each call is anticipated to last for about 15 to 30 minutes. For participants in the control group, they will receive the Life with PF booklets, the web link to access standardized information on the LFA website, and attention control calls by phone or Zoom at the same time points that the participants in the intervention group will receive their calls. So these calls will be general in nature. No health advice will be provided during these calls, and the participants will be directed to their usual healthcare team if they need any health advice. So once the participants complete the 8-week intervention, so after the last call, they will be asked to complete the 4 questionnaires again and to wear the stopwatch again for 7 days. And once the end of study assessment is completed, we will invite those who are in the intervention group to take part in a qualitative interview. The purpose of these interviews is to get some feedback and insights into the participants' experiences of using the intervention. The interviews will be semi-structured and conducted by telephone. We aim to do these interviews within 2 months after the participant has completed the intervention. An interview guide will be used, which covers questions such as the barriers and facilitators to access the modules and setting a health goal, as well as the delivery of the intervention. So these interviews are expected to last for approximately 30 to 40 minutes, They will be audio recorded and transcribed verbatim within 2 weeks following the interviews by the same researcher who does the interview. So these are my next steps. For the pilot study, I aim to recruit 30 participants by the end of this year, maybe early next year, and then complete the study by April next year. So far, we have recruited 7 participants. And in terms of the scoping review, I haven't got much time to talk to you about it today, but I aim to publish the scoping review results around September this year. So far I have completed the search using 5 electronic databases, and almost 21,000 references were returned. So it did take a bit of time to go through all of them, but data extraction has now been completed, and I'm currently just preparing for the manuscript and generating some summary tables. So we're getting there. So I want to take this opportunity to thank everyone who has ever helped me through my PhD journey, especially people on the list here. Thank you so much. I'm so grateful for your support and your help. And that's it. Thank you for listening. I'll stop sharing now.
Thank you very much, Joanna. That was fabulous. I think it was very commendable, the degree of rigor that you've gone into designing the intervention package. I can't think of what more you could have possibly done. I am just sort of wondering about the assessment of outcomes and what would be your definition of success. I mean, some of the things I think I saw in the primary outcome measure was something like 30% of people selecting one goal. And I mean, to the uneducated, that sounds like kind of a low number. But from a clinically meaningful positive outcome from this study, which then might encourage you, in perhaps partnership with the Lung Foundation, of expanding it as a national sort of thing, what would you be hoping to achieve?
That is a very good question. Thank you, Paul. I think it would be really nice to, I guess self-management is trying to get the patients to be more, actively involved in their care. So I think if we could at least help some of these patients to, at least be aware of some of the resources that are out there, that would be a nice first step. And then to help them to feel more comfortable and confident to actively involved in their care and making decisions about their own care. That would be, that would be really nice. I think that would be some of the things that I'd like to achieve by, moving forward.
Look, I guess that sounds fine, but I guess in terms of a objective scientific evaluation of the outcome, can you put some numbers around that? I mean, I guess I'm sort of thinking about, when we think about asthma action plans and COPD plans, there are some hard sort of things like exacerbation frequencies, hospital admissions, things of that nature, as well as slightly less hard, if you like, things I suppose like quality of life and so forth. So, if the idea of this is to actually develop it as an ongoing resource, are there some numbers in terms of improvements of quality of life or reductions in healthcare utilisation and things that you would like to see to be able to promote this?
I guess we are, that's what we're trying to do now, to get some preliminary data to have a look now to see what would be the important numbers that we want to define here. So you mentioned about the healthcare utilisation. That is a very interesting outcome, I think, which Anne and Gabriella and myself, we have spoken about it a few times as well. So we're not sure whether that's actually going to be the same as the other lung diseases, such as, you know, COPD, where hospital admissions might be reduced, and then, you know, healthcare utilization might be reduced because they can self-administer medications or self-manage at home for the exacerbation a bit better than what people with PF can do. So, but yeah, so I think we look forward to getting the results and, you know, getting our preliminary findings from this pilot study, so we can perhaps have a bit of a clearer idea or numbers that we can, you know, that we can sort of base on for our future research and clinical trials.
Sure. Okay. Thanks.
I hope I answered your question.
Look, it's a tricky one, isn't it? I guess. If anyone has questions, please use the raise hand function. I see Karen Simon's name there, who does a lot of support for patients in the IPF space. I don't know if you're listening, Karen, but I just wondered, from a nurse who does a lot of IPF support, what would you like to sort of see come out of this that would then encourage you to actually sort of advertise it to your patients and hand out the package?
Yeah, thanks, Paul. I am still on the line. You know, I think it's a great project that Joanna's doing, and yeah, we've got 7 patients recruited so far. You know, and it's just interesting way to see, you know, how would patients like to receive education in the future, you know, and the best way that we can provide resources to them, because all of us have very busy services, and you know, the best way that we can educate patients and, you know, make them aware of what is out there to help them, you know, I think it'll be really interesting to get the results, and yeah, we'll certainly be utilizing it in our service.
Okay. Perhaps I'll tap Anne on the shoulder for comment in terms of, I mean, your team obviously invests your heart and soul in this sort of stuff, so you're keen to get it out there. But when you're trying to sell it to clinicians out in the real world, beyond Monash and the people who are already converted, perhaps even promote it, dare I say, through the Thoracic Society or the Lung Foundation, what would you like to see?
Yeah, so I guess what you're asking for is what's a clinically meaningful outcome that, you know, might do 2 things, might get the next trial funded, but also might make it worth implementing it in practice. And, you know, Joanna alluded to the fact that in other self-management areas, we've been very successful with keeping people out of hospital, and that's an outcome that means something to patients as well as meaning something to the health system. We're just not sure whether that will be the case in PF, because these are patients who aren't hospitalised terribly much anyway. And if they are, you know, it can often be a poor outcome. So whether that's the right outcome, I'm not sure. We've put symptom and quality of life measures into the pilot study because that's probably, I think, more likely where we would get to. It would be interesting to see if we can achieve some of those other sort of more behavioural outcomes as well, I guess, that we think are important to long-term PF prognosis, things like, you know, increased physical activity, better use of oxygen, you know, better communication with health professionals. But if I had to punt on what I thought would probably be the outcome that would come out of it, I would say probably it's going to be a quality of life outcome, I would think, and perhaps disease mastery as well. I'm not 100% convinced about the healthcare utilisation yet. Sure,
Fair enough. All right. Anyone else have any questions or comments? All right. Well, Joanna, we might wind it up there. I mean, it's a fabulous body of work, and certainly I think you can see the finish line looming ahead for your PhD, so that's great. I hope your recruitment doesn't get too disrupted, but it sounds like you're off to a great start if you need 30 and you've got 7 so far, so good luck.
Thank you. Karen has been very helpful in this process, so thank you, Karen.
Great, good on you. All right then, well look, I'll finish it there. Just a reminder for those of you who in the Create program with the professional development weekend we're having early November. I think there's been a lot of emails circulated about that. So if you haven't done so already and you'd like to be a part of it, Kate's been sending out some emails with some forms for people to express their interest. So I think that's going to be a good opportunity, hopefully, unless there's another COVID explosion, which we hope is not going to happen. We're frantically trying to keep things going at the moment, but at the same time, a little bit anxious about a whole bunch of health professionals getting together. But hopefully the world will improve by then. All right. Well, and look forward to, we'll circulate the announcement for next month's meeting and catch up with you again then. And in the meantime, stay safe and get all your vaccinations. Okay.
Thanks, Paul.
Thank you, Joanna, very much.
Thanks,
All right.
everyone.
Thank you.
Thanks,
Joanna.
Goodbye.